Hello, everyone. This is Jonathan Marks from Inkwell Medical Communications and also ADHDinadults.com, and we're back with you today with another Ask the ADHD Expert session. We do these monthly and get your questions answered. Today, we're talking about ADHD facts and fiction, and we're with Steve Ferrone, who's from SUNY Upstate Medical University. Steve writes blogs for us, and he started a blog series on ADHD facts and fiction, and I really thought it was so informative that it was worth turning it into a webinar to better educate everybody about what we do know today about ADHD and what's false as well. If we can go to the next slide, Steve. ADHD in adults, just as a reminder, we have quite a number of offerings. We have free online CME. We have a YouTube channel with video briefs for everyone. We've got a blog. We're very present on social media. We have this Ask the ADHD Expert sessions, and then we also have collaborations with a number of different organizations around the world who are interested in working with ADHD patients and educating professionals. Next slide. And so we will start the presentation now. ADHD Facts and Fiction. Steve Ferrone, how are you today, Steve?
I'm doing good, Jonathan. Thank you very much. And yourself?
Great, thank you. Tell us just a little bit, just briefly about your history. You've been working in ADHD for a long time.
Oh yeah, I've been studying ADHD for over 2 decades. I'm a clinical psychologist. I no longer treat patients, though I did a while back before I devoted myself full-time to research. And I'm also very much a proponent of providing evidence-based education, which is why you and I developed ADHDinadults.com. Also through my work with the American Professional Society of ADHD and Related Disorders, where I'm on the board, and the World Federation of ADHD, where I'm the vice president, I really try to help communicate to the world of practitioners the newest and most evidence-based data about ADHD.
Great.
So let's move on to talk about the facts and fiction about the disorder. ADHD is kind of unusual compared to other psychiatric conditions in that it is periodically attacked by a variety of special interests in the media, sometimes trial attorneys. There's the Scientology group that has a strong bias against psychiatry in general, but also ADHD in particular. We see some celebrities talking about it in a very bad way. Popular books will sometimes claim that ADHD doesn't exist, or other myths of that fashion. And so I've fashioned a series of blogs to address some of the common myths about the disorder, and we're going to summarize them here in this talk. As just one example, and there are many that I could show you, of the kind of methodology that is published even in what are considered to be respected venues such as Psychology Today. Here is a Psychology Today blog entitled, "No, there is no such thing as ADHD." This is a classic criticism saying that children with ADHD are, quote, normal kids who are just a little bit different, and they're being medicated and treated for no good reason at all. It's ridiculous, and we'll find out why as we move along to the presentation. Well, the first fiction is that ADHD is routinely overdiagnosed. We saw this recently in the New York Times article last year regarding some data that came out from the Center for Disease Control. However, when this issue has been looked at empirically, particularly in this review article by Scioto and colleagues, they concluded very clearly that the available evidence from prevalence studies, research on the diagnostic process, was very clear that there's no justification for the conclusion that ADHD is systematically overdiagnosed. Quite simple. I do refer you to that review article to read. It's very interesting and thorough, and describes all the issues that are relevant to this topic. Frequently, when you see an article in a place like the New York Times that talks about overdiagnosis, they pull one number out of a big, giant table of numbers, and they pull the number out that's most consistent with what they would like to say. And as a good example, in that CDC report, New York Times complained the disorder was overdiagnosed, but in effect, in reality, I mean, when you looked at the results, the rate of treatment for ADHD was about, I think, 4.5%, 4.6%, which is exactly what you'd expect from epidemiological studies. These are the CDC data. There is, as you can see, some wide variation among the states. There are some places where prevalence rates are very high and some places where they are relatively low. An important point here is that these data are frequently reported as diagnoses of ADHD. This is simply a parent telling somebody on the telephone that sometime in the child's life somebody told the parent that the child had ADHD, or I should say a clinician told the parent that the child had ADHD. So they're not diagnoses, and it's not surprising that the numbers are high because it's a very loose definition of ADHD. Now here's what we look at parent-reported medications. As you can see, the numbers become much lower. In most states, the numbers are pretty close to the prevalence rate. I linked the prevalence rate to a recent meta-analysis of all epidemiologic studies around the world, which basically concludes that the prevalence of ADHD is about 5%, give or take a few percentage points. And almost all of these prevalences are within the expected range, except for a few. And there may be some concerns about some of those states in the dark green where someone needs to take a look at diagnostic practices there. But clearly the disorder is not routinely overdiagnosed, and one might even argue that in some states, like for example Nevada, where it's 2.0%, the disorder is not being appropriately treated.
And so the average rate of ADHD in a population is what, Steve?
The average rate is roughly 5%. 4.6%, I think, was the meta-analysis finding. Roughly 5% in youth. Mm-hmm. In adults, it drops down to more of around 3.3% was the result from the meta-analysis there.
Okay, good. So that's the kind of the number that we're looking for as a normal rate.
That's the number we're looking for. And in fact, when you see this next slide here, these are the CDC reports of parent-reported medication. You can see that, first of all, there was a significant change in 2007 to 2011, but in both years, the prevalence rate is right where you expected, around 5%. Mm-hmm. So the idea that the disorder, again, is being overdiagnosed and overtreated is not true, certainly not on a wholesale basis across the board in the United States.
And is this something you see internationally? Is this a rate you see internationally?
Yes, the number I gave you, that 5% number, comes from a very comprehensive analysis of, I think, hundreds of studies across the world. Most of them from the United States, Europe, Australia, Scandinavia, but some from Africa and the Middle East and Asia. And essentially the prevalence is pretty consistent across the world. There were some unusual numbers that came out of the Middle East, I think, which was trying to understand the rates. They were a little bit lower. But that just needs more research. There's not much research there, and it could just be that the studies there were not quite accurate. But if you look across the board, there's really very little geographic prevalence. Most of the difference in prevalence is explained by the method used to define the disorder. So, for example, the CDC used the method just asking the parent, did somebody tell you your child had ADHD? That leads to a higher rate of prevalence of the disorder because it's understandably not a very precise methodology.
Right. And so 5%, I'll just say one more thing and then we'll go on. So 5% is 1 in 20. So if you're a healthcare professional and you've got more than 20 people coming through your office every day, it's likely that more than one of them has ADHD, and you should be aware of that possibility.
That's right. If you treat adults, it's a little bit less than 1 in 20, but it's still up there. It's between 1 in 10 and 1 in 20. And importantly, for the primary care doctor, it's probably higher than the population prevalence because the primary care doctor sees people who have anxiety disorders and people who are depressed, and they frequently treat those disorders. The prevalence among those people is much higher. Mm-hmm. And there's no doubt about it. If any primary care doctor is treating depressed patients or anxious patients and they don't diagnose ADHD at all, they're missing the diagnosis because they should be getting about 30% of those depressed and anxious people should be criteria for ADHD.
Great. And we have other sessions which are very informative on diagnosing and screening for ADHD. We won't go into that there, but it's just to kind of put a pin in that point. Go ahead, Steve.
All right, so to turn that to adult ADHD, this is a report that was done on medication trends by a company called Express Scripts. They study medication use and periodically put out reports mostly aimed at industry to try to understand trends in prescriptions. And here they're looking at prevalence of treatments from 2008 to 2012, and they looked across the range of ages 4 to 64. And we'll talk here about how the percent of the how medication use changes in the population by age. So let's start at that line at the top. The red line is kids 12 to 18, and there your prevalence of medication use starts at around 5.5% and is going up to 7%. Again, that's within the expected range. I told you the mean was 5% across studies, but there's a range that we expect. So that's maybe go from 3 to 7%. We're getting to the top of the range in the U.S. where we're treating most of the cases. It's less in the 4 to 11 range. That's the blue line, the light blue line. Those kids are younger. We would expect that. Oddly, it's low in the 19 to 25 range that the prevalence is going down pretty dramatically. The disorder does tend to remit in adolescence and adulthood, and that may explain why we're seeing lower rates in some of these, some young adults. By young adulthood, about 2/3 of cases remit, and you can see the treatment here is, it's almost about 2/3 lower than it is among adolescents, which is kind of what you'd expect. So this could be, these data do kind of track what we see as the epidemiology of the disorder. Now, we don't know very much about the real prevalence of the disorder at later ages, such as in the 30s, 40s, and 50s, and so forth. We can see from these treatment data that older people are much less likely to receive treatment. We start to know now whether that's under treatment or not, just because we don't have enough real good epidemiology in those age groups. We certainly know it's not over-treatment because they're very low rates. You're talking almost 2% or less for these older age groups.
And so isn't some of this lower rate explained, Steve, by the fact that ADHD has been believed until the mid-1980s that it was just a childhood disorder and it really was not diagnosed in adults? Could this be some of the reason for the lower treatment?
That is the other problem, yes, because there was a strong belief in the 60s, 70s, and 80s that ADHD remitted by adulthood. It was considered to be a disorder of developmental lag, and the brain would catch up, and everybody by adulthood would be normal. That's been shown to be false. That's been shown by my colleagues and I in work that we've done where we've followed children up from childhood into adulthood, and other studies too. Many groups now, there are probably at least 10 longitudinal studies that have shown when you diagnose kids as kids, and you then look at them as adults, about 2/3 of them continue to have impairing symptoms of ADHD in adulthood. So the disorder now, not only is it recognized more by clinicians, it's been more officially recognized in the Diagnostic and Statistical Manual of the American Psychiatric Association, which now even includes modified criteria for adults, because the criteria that were developed for children weren't quite accurate enough and were leading to underdiagnosis. And so we now have better, more sensitive diagnostic processes for adults.
Mm-hmm.
Okay, so moving on to the next section. Well, we've talked a little bit about this already, which is that children outgrow ADHD. We'll see more of that data I talked about. Here's a graph that is not actual data, but it summarizes actual data from some work that I did back in 2006, which is a summary meta-analysis of many studies, of many of these follow-up studies that we talked about. So these different lines start at different ages because those are the different data sources that are available. And it's showing here. Let's just start first with the green line. That shows how if you apply the full diagnostic criteria for ADHD at different ages, what happens. And as you can see, there is a dramatic change here. You go from about, if you follow up young kids until they're around 10 years old, you see that 75% are persistent, but by age 25, only 15% continue to meet the full diagnostic criteria. And these are the kinds of data that have been presented before I wrote my paper, and people were thinking, wow, ADHD really almost disappears by young adulthood. So when I point that in my paper, well, if you look at functional impairment, which is the orange line, or impairing symptoms, which is the blue line, there's a much greater persistence of the disorder. So what the blue and orange lines tell us is that really by age 30, still about 2/3 of ADHD youth continue to have some kind of functional impairment that's associated with ADHD. They no longer have all the symptoms of the disorder, but they have some symptoms and also real impairment. So these are people who walk into the doctor's office and they say they need help for these problems that are ADHD related, but it's difficult to pin down an actual diagnosis at that time because they may only have 2 or 3 symptoms in some of the more milder cases. But if you look into their history, they have a history of the disorder, which suggests that they really do have the condition. So it's very much like a patient with schizophrenia will have a full-blown diagnosis at age 17. By the time they're 30, they may not meet full criteria for schizophrenia when you see them in the office, but they still have impairing symptoms of the disorder. We were talking before about what's the prevalence of adult ADHD. These are the studies that have looked at adult ADHD in different populations across around the world, mostly in the United States, with some in New Zealand, Italy. I think we have Netherlands represented as well. Pool prevalence is right around 3%. So that's kind of consistent with the idea that you start with a prevalence in childhood of about 5-6%. It goes to about 3% in adulthood. Many fewer studies of the prevalence in adulthood compared to childhood, where we have hundreds of studies. In this particular graph, these little dots tell you what the prevalence is, but those horizontal blue lines give you the accuracy of the estimate. As you can see, those lines are very wide, meaning that individual studies aren't quite accurate. But the pooled prevalence at the very top is a fairly accurate estimate, suggesting the true prevalence of adult ADHD is between 2 and maybe 3.5%.
So again, pretty consistent with the numbers you talked about before, and that ADHD is not being overdiagnosed.
Exactly, that the disorder is not being overdiagnosed, that there's a lot of people out there, talking in the probably tens of millions, who have the disorder and need to be treated. When we talk about the course of the disorder, I'd like to use this little cartoon that gives the main points about how the symptoms of ADHD change over time. And the story is really quite simple, that symptoms of hyperactivity and impulsivity tend to decrease, whereas symptoms of inattention tend to stay the same. And that means that the child who is running around and climbing on furniture and impulsively running into the street after toys and so forth, stops those hyperactive impulsive behaviors and becomes more kind of inattentive, distractible adult who has a difficult time focusing at work. They may, if they show hyperactivity, they may show it in very mild forms. For example, they fidget in their seat when they're sitting at meetings, or they just can't tolerate long meetings where they have to sit down, so they don't show up and they're not paying attention when they're at these meetings. The inattention often generalizes into what we call executive function deficits, where they have difficulty with organization, difficulty understanding abstract constructs, importantly, difficulties in time management, which makes it difficult for them to be on time for work, makes it difficult for them to schedule things, and often causes real functional impairments in terms of their ability to hold a job. We do know from the data of adult ADHD that they have a more difficult time maintaining employment than people without ADHD. So this last comment is related to this next section, which is this section that ADHD is not a disorder, it's just the extreme of normal behavior. And we saw that in the Psychology Today blurb at the very beginning, and I see this over and over again in some of the press items about ADHD. The theory goes that, well, everybody's a little bit hyperactive and inattentive, and so if you're at that extreme of normal behavior, you're really don't have a disorder, you just have an extreme trait, an extreme human trait. Well, why is that wrong? First of all, I'm going to show you some data about the significance of this extreme behavior and how it really causes real-world problems that are, in some cases, dangerous to the person's life and limb. This is the example of traffic accidents and another meta-analysis. In this particular meta-analysis, outlay that's that diamond at the bottom, the middle of the diamond, that shows us the pooled result, which is about 2, which means that having ADHD doubles one's risk for having traffic accidents. This has been seen from multiple studies. There's not a lot, but every study that has looked at it has found a positive finding, which you can see by the individual studies here in the graph, all having their little dots to the right-hand side of the 1, where 1 is no risk. Anything greater than 1 is an increased risk.
Wow. So the average of those studies is that, as you said before, if you have ADHD, you're twice as likely to have a traffic accident as a normal person.
That's exactly right.
Right.
If you're normal, you still have accidents, but if you have ADHD, your risk is doubled.
Wow.
This is another way another meta-analysis shown in a different kind of plot. At the horizontal line is, again, the odds ratio, which is the increase in risk due to ADHD, in this case on having future substance use disorders. And this is very clear across these different substance use disorders. Now, each of these substances, as multiple studies have contributed to this. All of these findings are statistically significant, which was true for the traffic accidents as well. And we can see here is that depending on the substance, you have between a 1.3-fold to a 3.5-fold increase in risk for drug abuse, drug and alcohol abuse, if you have had ADHD in childhood. It's greatest if we lump all the drugs together. That's the 3.5-fold increase in risk. So serious outcome substance use disorders in adolescence and adulthood if you had childhood ADHD.
And this is important for clinicians. This is important for clinicians. Steve's just giving you 2 hints here. If you ask your patient about traffic accidents or any kind of substance abuse, this can be an indication of the presence of ADHD.
Absolutely, very good point. When you hear about these kinds of impairments, you should suspect ADHD could be behind this, and you should ask the questions or give an appropriate screening tool to screen for ADHD symptoms. The substance abuse data are particularly interesting because we do know from naturalistic studies that children who have been, in some cases, it appears that children who have been treated for their ADHD during childhood have a little bit of a lower risk for substance use in adolescence. But those data are a little bit, I will say, weak still. There's a signal in the data, and we're looking at those in more detail to see if that's the case. But there's a particularly good study from a very large population register of millions of people in Denmark, which showed that treating ADHD tends to lower the risk for subsequent substance use disorders. Now, another hard outcome, if you will, and serious outcome is being in prison. This here is looking at the prevalence of ADHD in prison populations. This is, again, a meta-analysis, which is a summary of many studies. And looking at males and females and adult and youth populations. And as you can see, in all of these prison populations, you have a prevalence of ADHD, which is about 25%. And that's huge. And that's, if you look at the adult population, it's more than a 5-fold increase in risk in the adults to be in prison if you have ADHD. Why is ADHD landing people in prison? Well, clearly, if they're substance abusers, they break the laws around substance use, then that will get them into prison. But it's more than that. If they're impulsive, they may be more likely to commit crimes. If they're substance users, they may be more likely to develop peer relationships that lead to relationships with other criminals. So this, again, is very important data. And again, regarding treatment, the big registry studies from Scandinavia show that people with ADHD are much less likely to commit crimes if they've been treated for the disorder. And they're also much likely to commit crimes. Oh, sorry about this.
That's okay.
This can affect your...
there we go.
Is that going to show up in your... Okay.
Yeah, that's okay. Don't worry.
Okay.
Yeah.
Okay.
So
Anyway,
what you're saying here, I mean, again, the important point, 25%, are you saying 25% of the prison population has ADHD?
Has ADHD? Absolutely, yes.
Wow.
25% has ADHD.
So this is one of the ways we treat ADHD in the society.
Frankly, that's true. It becomes an outcome for people who are treated that they end up in prison as opposed to being appropriately treated. There are now some projects going on now. I know one. Actually, there's one in the United Kingdom, another in Denmark, where they're treating prisoners who have ADHD and trying to see if it has an effect on subsequent recidivism. We don't know that yet. These are all very new studies that have just started, but they may have a big impact on how ADHD people are treated in prison populations.
Right.
Another hard outcome, meaning a serious outcome that's easy to measure, that everybody agrees is a real outcome and an important one, is employment. Here we're looking at the employment of people with ADHD in blue and people without in yellow. And what's interesting here is that in this paper I did with Joe Biederman, we're looking at people with ADHD with different levels of education. So all the way to the left are people with less than high school education. As you can see, if you have ADHD, you're less likely to be employed than if you don't have ADHD. Now, as education level increases, employment levels tend to increase, but at every level of education, the ADHD people are doing worse. So even if you go to the postgraduate degree, so these are ADHD people who are, entirely intelligent, are able to get through college, are able to get a postgraduate degree, like a master's degree or a PhD or an MD even, or a law degree, and still the employment rate is less for people with ADHD than without. So even among highly talented people, ADHD is hurting their performance.
Mm-hmm.
And finally, let's talk about the worst outcome of all, and that's mortality. This is a almost shocking study that comes from the Danish population register. They looked at this population register, which includes over what they call 24 million person years of coverage. That means you take the number of people by the number of years, you multiply them, and you get 24 million person years of coverage that you've looked at.
Mm-hmm.
And the short story here is that the increase that ADHD increases the risk for premature mortality in children, adolescents, and adults. So if you look at the age groups on the left, you see the very young children. The mortality rate is given in the third column. And those mortality rates, like for example, 3.3 for the very young, 4.3 for adolescents, and 22.3 for adults, are all greater than 1, indicating that there is a increased risk for premature mortality if you have ADHD.
Now, is this as a result of ADHD, or is this as a result of something else?
Well,
do we know?
Question. So it's not. We don't think. Yeah, good point. We don't think the pathophysiology of ADHD itself, is fatal.
Yes.
But for example, in the Danish study, large fraction of the deaths were accounted for by accidents, which is not surprising given the data we saw before in traffic accidents, but other types of accidents as well.
Yes.
But there was also a subset of deaths that had nothing to do with accidents, and they're still looking into that to see exactly what those deaths were due to. We do know that ADHD, for example, increases the risk for obesity, and it may be that some of these deaths were due to diseases that are related to obesity.
Mm-hmm.
But that remains to be seen. But very importantly, ADHD increases the risk for premature death. And that's a very large increase in adults, but it still even exists for the young.
Right.
So this is why in 2000 the U.S. Center for Disease Control drew the conclusion ADHD is a serious public health problem. I mean, they made this conclusion long before the Danish study did their work on mortality, but there were other data available. So this is not an issue that is peculiar to psychiatry or psychology, to academics. When the CDC took a look at all the data, and they had some meetings of experts down at their offices in Atlanta, they drew this very strong conclusion that it's a serious public health problem, which is why they've been studying it in their own research labs to get a better understanding of the prevalence around the country.
Mm-hmm.
The Agency for Health Care Research and Quality, which happens to be the organization that funded the ADHDadults.com website, has also identified ADHD as a priority issue for professional education. And this has led to the website, led to this presentation, and all the blogs and other types of education material you can see at ADHDadults.com.
So, Steve, before we go on to this next one, and you can stay on this slide, but you really, if we go back and say, gee, ADHD is just a slight exaggeration of normal behavior, you've just shown us a series of poor health outcomes for ADHD patients, which really kind of, indicate that ADHD adults and ADHD kids even have seriously different health outcomes from the normal population, and we need to take them seriously.
Absolutely, and I'm glad you stopped me for that second, because it reminded me to say one last thing about this. And it has to do with a misunderstanding amongst the people who talk about ADHD as an extreme trait. Because even if ADHD is the extreme of a normal trait, that's no different than, for example, saying that hypocholesterolemia is a trait. Everybody has a cholesterol level, but some people have levels that are so high, we decide that it needs to be treated medically. Mm-hmm. And we choose a cut point. We choose a cut point on that distribution to make that decision about treatment. and then the patient's treated to avoid adverse outcomes.
Mm-hmm.
For ADHD, it may be that the situation is similar, that there is, in fact, there is a distribution in the population. If you go into the population and you measure ADHD symptoms, you will find there's a range of distributions in the symptoms,
Right.
where only a few people have very high levels and other people have lower levels. But just like high blood pressure or high cholesterol levels, we have to make the decision as to when treatment is needed, and that's because we're trying to prevent all of these adverse outcomes associated with high levels of symptoms.
Right. Good.
So,
okay, on to the next one.
So another common fiction, this started out in actually it was very common in the 60s and 70s that ADHD in kids was only treated during school. The ADHD was sort of seen as a cognitive school-based disorder. It interfered with school performance, but it really wasn't very relevant outside the school setting. And then when adults were being treated, sometimes that got generalized to, well, adults just need it for when they're working, they don't need it on the weekends. And so the fiction here is that ADHD only affects these isolated areas and therefore only has to be treated during school or during work. Well, as it turns out, if you look at the month-by-month utilization of ADHD medication, as Express Scripts did here, there actually is a dip in the use of ADHD medications for children. That's the red line, at least, during the summer months, which means that many doctors are still taking medication away when a child is no longer in school. And you see for the red line, which is the adolescents, and then the light blue line, which is the very young kids. You don't see it, interestingly, for the adults, young adults or older adults, which makes sense because they don't have school holidays, and therefore doctors probably don't think the medication should come off. Now, whether this is appropriate treatment or inappropriate is impossible to say from these data because they're population data. They didn't really look at the effects it had on children. But any physician who is taking medication away in the summertime really does need to do a very close monitoring of that child to make sure that the lack of medication is not interfering with other aspects of their life, particularly socialization, which is still continuing in the summertime. And remember, kids are still at risk for accidents during the summer as much as they are during the school years. In fact, maybe at greater risk because they're not in school and they're out and about doing all sorts of things. The lifetime impairments of ADHD, we've discussed some of them. This diagram is a nice way to summarize what we've seen as the lifetime risks over time, starting in preschool with disruptive behavior, moving into the school-age years, academic failure, poor socialization, self-esteem, injuries. In adolescence, and comes substance use, car accidents, crime perhaps. Substance abuse typically starts with smoking and then can lead on to other substances of abuse, continuation of low self-esteem, and then college age and adult, academic failure, occupational failure, substance use, chronic abuse, and perhaps incarceration due to crime. As adults, relationship failures. ADHD adults less likely to be successful in marriages, for example. These chronic impairments that we see throughout life suggest that many ADHD people need to be treated not only throughout the year, but also throughout the day, because they're facing challenges that are both psychosocial challenges, educational challenges, occupational challenges. They're driving cars to and from work. They're seeing friends outside of work on the weekends. These are issues that affect them throughout the day and throughout the week, and therefore, for most, I would say, ADHD people, treatment is more of a chronic regime rather than targeted to specific times of the day.
Mm-hmm.
Yes, there are some people who might just need it for certain times of day, but it's really up to the physician to determine and to monitor it very closely to be sure that they're being treated appropriately. For ADHD children, it's also important to look at, well, actually it's true for both children and adults, that the ADHD has an impact outside the person onto the family. So the parents of ADHD children and sometimes the spouses of ADHD adults start to blame themselves, experience lots of stress, frequently social isolation if their child or ADHD spouse is so difficult that friendships are disrupted. Spouses and parents can become depressed, and you can have marital discord for sure among ADHD adults and their spouses, and even among the parents of ADHD children when they disagree about parenting styles, discipline, and so forth.
Again, before you go on to the next one, Steve, so divorce rates among ADHD patients, I think, are twice what the normal divorce rate is. Is that close?
Yeah, that's right. So that's close. Yeah, I don't have the figure at the top of my head here, but yes, ADHD people are more likely to have relationship failures, either outright divorce or unhappy marriages, because of their ADHD. And it kind of makes sense when we think about the symptoms of the disorder and how they impact other people.
Mm-hmm.
So let's talk about this concept that ADHD is an American disorder. I actually wrote a paper about this many years ago. The idea here is that, well, in the United States we have these either permissive values, which we let kids get away with things, and therefore they're out of control, or we have the super competitive environment, so people, in order to compete, well, they kind of break down under a competitive environment and they experience symptoms of ADHD. This was very popular in the 1990s and even in the early 2000s, and it's still popular in some segments of the population today. So here you got a painting that I saw actually last year, and it's from a Dutch painter, and it was done sometime in the 17th century. I don't know exactly when, and he's describing a school for boys and girls about 1670. Well, what do we see here? We see exactly what you might find in a different kind of format in an American school. You've got some kids who are studying attentively, doing their work, and you've got other kids who are causing problems, playing games, certainly not attending to their work. One looks like he's sleeping. So, yes, they did have ADHD back in the world of the Dutch in 1670. This is not a new condition, and it's not an American condition by any means. And in fact, if you take a look at the history of ADHD, which me and my colleagues summarized recently, the timeline of when ADHD has actually been, if you will, recognized in some sort of medical or psychological text goes back to 1775.
Wow.
Now, when I say here that this German textbook in 1775 described an ADHD syndrome, I don't mean that they use the word ADHD or attention deficit disorder or anything like that. What I mean is that if you go read that textbook, you've got a description of children who are showing symptoms that today we would say are ADHD symptoms. This was seen in the German textbook, 1775, and then in 1798 there's a Scottish textbook, another German book in 1845. The first appearance in the medical literature, there was a journal article, was in 1901. That was in the Lancet, where Dr. Still described a disorder which he called defect of moral control. It's an odd-sounding title to us now, but that's because the word moral was used in a different way. But essentially, he's describing ADHD kids. And then as the 20th century progressed, we began to see a few things happen. First of all, there was a big epidemic of encephalitis in the 1940s that created this minimal brain dysfunction in youth, and they ended up looking very much like ADHD kids today. They were described as having minimal brain dysfunction. But even before that, these kids had been identified, not kids with encephalitis, but kids that we would have diagnosed as ADHD today, and they were being treated. There's a hospital in Rhode Island. It's now called Bradley Hospital after the Dr. Bradley, who in 1930 found that using benzodrine, which is an amphetamine, reduced hyperactivity in children that were at this being treated in this day hospital setting. And it's a long story which you should read, but he basically discovered this by accident. He gave these kids amphetamines for another reason, thinking it would actually cure some headaches. And after the day he gave it to the kids, in the afternoon, the teachers came to him and said, "What did you do to these kids? They're so much better today than they were yesterday." Mm-hmm. And he followed it up and found the first treatment for ADHD in the 1930s. So this is nothing new, ADHD. And we can go through the whole history, which I won't because there's a lot of detail, but essentially, it certainly took until about the 1980s until we had a very well-defined diagnostic criterion. And the word attention deficit disorder emerged in the early 1980s as an official diagnostic criterion. But the main point here is that there's nothing new and there's nothing American about ADHD. It's been around for quite a long time. And in fact, we'll go back to talking about the prevalence of ADHD, which we were discussing earlier. This is a summary of those data looking around the world. And if you look at the very bottom, the worldwide estimate from 100 studies is, as I said, about 5%.
Right.
And it's pretty consistent with some outlying studies in Africa, South America, and the Middle East. But again, those long error bars, the horizontal bars, tell you that those estimates are not very exact. And in fact, they don't actually differ statistically from the 5%. So they're probably not unusual, and probably would go back to 5% if we had more studies or larger studies. But very clear here that ADHD is, you're finding it around the world. It's not due to the American environment or any features of the American environment. Well, for ADHD in childhood, there was a common belief in psychiatry many years ago in the 50s and 60s that it used to be called blaming the parent. Poor parenting caused everything. Poor parenting caused schizophrenia, and then poor parenting caused ADHD. And this led to the corollary that, well, these disorders aren't biological. They have to do with the psychosocial milieu of the child, and we don't really have to think about what's going on in the brain. Well, we know that there's now a very strong biology of ADHD. We see this in twin studies that are documented on this slide. And these are studies that estimate the degree to which ADHD is heritable. So 0 would mean that genes have no effect on the disorder. 1 would mean genes are totally account for the disorder. The mean here is about 75% across studies, which suggests that genes play a substantial role in causing ADHD. Now, importantly, these twin studies come from around the world. You have them from many from America, many from Europe, Australia, Scandinavia. None from other countries besides those regions, but a nice selection of countries, again, which suggests that this is not an American condition, and the heritability is the same around the world wherever it's been measured. The genetics of ADHD is very complex, but this slide summarizes it nicely. Essentially, we know now that there are some very rare cases of chromosomal anomalies. These can be deletions of part of a chromosome or extra chromosomes. And these rare anomalies cause well-described syndromes with many problems. But in some cases, people with these syndromes also have an ADHD diagnosis, ADHD symptoms. These are extremely rare, maybe 1 in 10,000 or even less. And then you have your rare, what we call our rare variants. And these are the less than, say, 1%. And these are, right now we know that there are variants which are called copy number variants, which are smaller insertions and deletions in the genome that are associated with ADHD. What we're beginning to understand are the common variants. We know now that they explain about 40% of the heritability. And by common, I mean more than about 5% in the population. And so far, current data suggests that they affect neurotransmitter systems in the brain, like dopamine and norepinephrine systems, but also systems like neurite outgrowth, which control the formation of synapses and the development of the brain after birth, which could explain how the brain is miswired very early in life, leading to ADHD.
Steve, before you go to this slide here, I just wanted to ask a question. You talked about the twin studies, but I'm just curious, what is the heritability of ADHD between parent and child? I mean, if you have a ADHD parent, what percentage likelihood is that you'll have an ADHD child? Do we know that?
That's a good point. So we do know that. In the studies that we've done, it's fairly high. It was about, in one study, it's at 50%. I would say a little bit lower in another study. So good estimate would be, say, 30 to 40%, based upon the studies that are out there. If one child in the family has ADHD, the risk of the other child is more like about 25%. The risk for the parent is about 25%. So that's an important point, Jonathan, because the disorder tracks its families, but it's not. It doesn't track in the sense that everybody in the family will have the disorder.
Right.
And this is exactly what you'd expect for what we call a complex genetic disorder, where the disorder is caused not by one simple mutation. It's caused, in most cases, it's caused by many different variants that are a little bit, if you will, a little bit off. The many genes that aren't working quite well. When you combine them all together, you get a disorder. And those types of complex disorders lead to these risks to relatives that are less than 100%, and typically around what we see for ADHD.
And is it true that you can kind of see this ADHD running through families, more rather than less? I mean, even though the percentage is 25 to 40, I mean, you still see ADHD running through generations.
Absolutely, and it's not unusual to find, if, for example, when in cases where adults haven't been treated, sometimes adults get treated because their child is treated for ADHD. In fact, I can recall a family where the child was being treated in our clinic, and then the parent said, "Gee, I had the same problems that my kid had.
Yes.
I think I might have ADHD." And then you do a history of the parent. The parent, this person did have, I think it was father, had ADHD, and was treated and subsequently did very well, and was a very successful outcome. And
Right.
then this particular family, the father's father comes in and says, "I heard you're treating my father and my grandson. I was like that too." And sure enough, this grandpa had ADHD, and when he was treated, he was doing much better in life with his treatment.
Right.
Again, it's not always that way 100%, but it occurs commonly. And the important message to physicians is that if they hear about ADHD in someone's family, they should think about the rest of the family members.
Yes.
So certainly, pediatrician treating kids should think maybe the parent has ADHD, so if they have to follow instructions for treatment, they might not do a good job unless their ADHD is treated. Or primary care doctor who's treating a family and has some adults they're treating, and they know that their child has ADHD. That should raise the red flag, saying the parent may have ADHD as well.
Good. I'm glad you brought this up. Great. Thank you.
Okay, so back to the brain. There's a lot of brain data now about ADHD, much of it in adults because they're easier to study. So what we've seen in these brain studies, this particular slide we're looking at is a meta-analysis of structural MRI studies. These are studies looking at brain volumes. And what this meta-analysis found for sure was ADHD people having smaller volumes in subcortical regions, particularly the lentiform nucleus and the caudate nucleus, but also in larger gray matter volumes in left posterior cingulate cortex and the precuneus. That is clear evidence across multiple studies that there's unusual brain volumes in ADHD. These are not, by the way, dramatic changes in the brain. These are small differences, usually around 4% differences between ADHD and controls. But they're big enough for us to say that this is one example of the miswiring that may have occurred in the brain, for example, due to genes that are regulating neurite growth and so forth early in life. Many other studies have looked at what's called functional magnetic resonance imaging, or fMRI, and in a meta-analysis of this is one example. In fMRI, you give somebody a task, and then you look at which regions of the brain light up when the person is doing the task. And what you find, you look for areas that are either decreased or increased due to ADHD, and that would mean areas of the brain that aren't functioning right. They're either working too hard or not working hard enough. Mm-hmm. So in these brains here, you can see areas of red and orange, which mean decreased activation in ADHD, and then areas in blue, which are increased activation in ADHD. And what these findings tell us is that there are parts of the brain, the ones in red and orange, that aren't working well enough. And so there are other parts that have to kind of work overtime to get the job done. Because the brain is kind of redundant. It can solve the same problem different ways. So for an ADHD person, it's solving it in a different way, but which may lead to less efficiency and may explain why they don't do as well on certain tasks as non-ADHD people do.
So again, we're showing here that this really has to do with brain chemistry and genetics as opposed to bad parenting or a lackadaisical upbringing.
Exactly. So we have to think of more than bad parenting when we think about ADHD.
Yes.
And this is not to say that parents don't have a role, and they do have a role in learning to correctly parent ADHD kids. But yes, the brain plays a very serious role in correcting these abnormalities. With treatment, particularly pharmacologic treatment, should be considered by anybody who has ADHD or who has a child with ADHD. Now, thinking of pharmacologic treatment, this is a very relevant slide because it's a meta-analysis of in vivo. That means in the brain, live in the brain, dopamine transporter density in ADHD adults. So the dopamine transporter is very important because it is the target of amphetamine and methylphenidate, two of the stimulant drugs that are most commonly used to treat ADHD, and they're highly effective in treating the disorder. What you can see from this slide, anything to the right of the slide says that ADHD people have more dopamine transporters than non-ADHD people, and everything to the left is the opposite. What the slide says is that most studies are finding that there's a greater density of dopamine transporters in the ADHD people, and that red triangle, or actually diamond, red diamond, it shows you the pooled result, which shows, yes, there actually is a small effect for greater dopamine transporter density in ADHD, which makes a lot of sense because if there's too many dopamine transporters in ADHD, then you think that blocking them is a good idea, and that's exactly what the medications do. They block the transporter and presumably bring it down to a normal level, normalize the patient's brain, which leads to a reduction in ADHD symptoms and subsequently then reduction in impairments.
Can it have a long-term effect, Steve, or are these all short-term effects, the medications?
Well, the medication effect on the transporter is almost immediate. It changes the transporter, it blocks the transporter, and it's an immediate effect. The medication has to be lifelong. It's in some cases the disorder remits and the medication can be removed. The evidence for whether you can actually change the density with the medication over time is actually kind of mixed. And so we're not going to get into that right now, but it's there is some evidence that medication normalizes other behaviors for ADHD people, and that they can do better over time if they've been treated, for sure.
Okay.
Those are all, of course, naturalistic studies. We can't do clinical trials in the long term for these people. Okay, moving back to the brain. So one way to summarize all the data on the brain would be to think about the circuits that are affected. So one set of circuits is what we call the executive control circuits or executive function circuits. And these are circuits that start in the midbrain. Some of the areas in the midbrain you see in the red and gray that project out to your frontal lobes and project up to the cortex. That areas of the cortex, particularly the dorsal anterior cingulate cortex, but also dorsolateral prefrontal cortex, these circuits control our ability to do complex thinking, our ability to organize things, temporal processing, an important function. It's also a role of the cerebellum in these executive circuits that you see here around temporal processing, which is impaired in ADHD. These circuits that allow higher order thinking are impaired in the disorder, and we think this is one of the reasons why particularly ADHD adults have difficulty adapting to new environments, difficulty doing well in certain circumstances, and for example, work circumstances where they have to be well organized, they have to be on time, they have to schedule themselves as compared to non-ADHD people. So think of executive function as the areas of the brain that control these higher order levels of thinking, and then control of our other behaviors by top-down control from the cortical centers. Now, there's another part of the cortex, what's called orbitofrontal cortex and ventromedial prefrontal cortex. There are also projections, and these are all mostly dopaminergic or catecholinergic projections we're talking about, coming from deep within the brain to these areas. These circuits here we're talking about tend to control reward and motivation. I like to think of these as the reward circuits. And reward circuits are very important for ADHD because regardless of how well somebody is able to think about their world and organize it mentally in their mind and on paper and on their computer, ADHD people also have deficits in the way they respond to rewards. So for example, there's a common paradigm that we use to test reward sensitivity called delayed discounting. You might ask a person, would you rather have $10 today or $100 2 months from now? Well, the ADHD person is more likely to want $10 today. That distant reward is not very appealing to them. They want to have it now, not later. ADHD people are very sensitive to immediate rewards as opposed to distant rewards. And that causes a problem because it's hard for them to think, well, gee, if I study hard, I'm going to go to college and I'm going to make more money, and be happier, that reward is just too distant and is not going to control their behavior.
Mm-hmm.
So these reward circuits, these are the same reward circuits, by the way, they're also affected in substance abuse, which may explain why ADHD people are at high risk for substance use disorders, because those cortical areas in the slide, ventromedial prefrontal cortex, are all involved in, if you will, reward processing, understanding the value of rewards that are in the environment. Also in the circuit is the nucleus accumbens, which is a center for the feeling of reward, feeling of reward and pleasure due to rewarding activities. Also, the nucleus accumbens is probably one of the more common regions implicated in substance use disorders. So now we're going to get to this question about brain abnormalities and stimulating medication, which we touched upon before. The fiction here, of course, is that these brain abnormalities are all caused by medications, that they're not actually due to ADHD, they're just due to the fact that doctors give toxic medications. Well, that's wrong, and let's talk about the data that shows that it's wrong. We'll start first with these structural MRI studies. Now, I have to say first that all of these studies are naturalistic studies. They're not controlled clinical trials, because you can't do controlled clinical trials over a long period of time. It's just not ethical, not feasible. And so the only data we have are naturalistic studies looking at, for example, in this case, across different studies, if you look at the percent of patients receiving medication, which is on your horizontal axis, and then you look at brain volumes, which is the measure on your vertical axis, what you find are, in this case, higher brain volumes. In this case, higher is more normal, that because we're talking about the caudate nucleus, that you find higher caudate volumes in people who have been on medication, suggesting that medication had somewhat of a protective effect on the lower brain volumes that we see in ADHD people. Now,
so Steve, are you saying that the medications actually increase brain volume?
Well, we don't actually know what happens here. So remember, it's a naturalistic study. So it's possible that for some reason the people who are given medications are more likely to have higher brain volumes.
I see.
It's hard to know whether, you could make that argument because we haven't assigned people randomly to treatment.
Right.
It's hard for me to believe that that's the case, but it is possible.
So it's an association at this point.
It's just an association, exactly. Probably the important thing here is that there's no evidence that being on medication lowers your brain volume, and that's really the key thing.
I see what you're saying.
There's no evidence that the medication is causing the problem. If anything, it's possible that it's helping it, but we can't say that too strongly because it's a naturalistic study. But no evidence at all that it's hurting, and that's good news for doctors, patients, parents, spouses, everybody. A similar analysis was done here, looking at in a functional magnetic resonance imaging study in the prefrontal cortex, and that red line is kind of showing you the fitted line from a statistical model. The purple points are the actual data points, and again, as the percentage of medicated patients increases, you have your effect size is getting bigger, which means that in this case, it means that the patients are showing more normal activations in the brain when they've been on medication. Or, I'm sorry, the patients who are more likely medicated are showing more normal activations in the brain. So again, evidence here that the being on medication is certainly not worsening a problem and might be helping it. Another similar study, same exact data layout, and you can see the same trend in the line, that the more patients on medication in the study, the more likely you are to show a more normal effect on these functional magnetic resonance imaging attention tasks and their effects on activations in the brain. So I'm not just, by the way, showing you the positive results. There are no negative results of this sort, or there are no results of this sort from these studies that show the opposite effect, but there's any worsening. That has not been reported at all. So now we're talking about substance abuse as an outcome, and some people have argued that, well, of course, ADHD people abuse substances. You're treating them with amphetamine and methylphenidate, and these are controlled substances which themselves are addictive and abusable, and so you're just causing substance abuse in these people. Why are you surprised that they have substance use disorders? Well, let's take a look at this particular fiction and see what the facts are about that. Here's a study I was a part of we published last year. And we're looking here at studies that have looked at stimulant treatment for ADHD and subsequent cigarette smoking. And again, naturalistic samples. You can't do controlled clinical trials for these types of long-term studies. These are long-term studies. We're looking at over several years, from childhood to adolescence. What's the likelihood of smoking if you have been treated for or not treated for ADHD? So in this data layout, 1 means no effect. Anything from the left to the 1 is a protective effect. Anything that's greater than 1 is what we call a deleterious effect. Only 3 studies showed a deleterious effect, meaning that ADHD treatment might have caused smoking. The rest of the studies are very clear and show the protective effect. And ADHD treatment seems to protect against smoking. And if you look at the very bottom, that's we say combined effect size across all those studies, there's a clear evidence that the exposure to or the use of stimulant treatment is actually lowering the risk for subsequent smoking. So this is pretty powerful evidence that there's actually a protective effect in a naturalistic study, and very clearly no evidence at all for the idea that ADHD treatment is causing kids to smoke.
Mm-hmm.
When we look at the data for marijuana abuse, it's a different finding. That if you look at the very bottom, the combined data are spot on 1.0, which means there's no increased risk and no decreased risk. So ADHD treatment is not affecting not affecting marijuana usage at all. And the data for other drugs is kind of more like the marijuana data right now in terms of the meta-analysis. But there was one recent study that came out of the Scandinavian registries and about millions of patients, which showed a strong protective effect. So I think that when the future meta-analysis is done, that will change, and we may see protective effects on marijuana and also on drugs of abuse. But again, most importantly, remember, these are naturalistic studies. The conclusions are weak, but there's clearly no evidence that stimulant medications are causing drug abuse or smoking. If anything, the evidence is in the opposite direction. That's the key thing.
Got it.
All right. Now, so another fiction that sometimes you hear is that, well, you really should try non-pharmacologic therapy before you try medication.
And if I can just say, I'm sorry, Steve, it's not sometimes you hear. I think this is a very popular fiction, which is that I think a lot of parents don't want to put their kids on medication, so they want to try something more natural. And I think that's quite popular. So yes, this is a big one to get here.
It's a big one. It's also a big one for adults, too. There are many adults who would rather, if I take a vitamin or psychotherapy or, medication is dangerous. And
yeah.
Certainly people should be concerned about taking medications. They should always look at the adverse effects and discuss them with their physician, but they have to look at the facts of the matter. They can't just assume that drug is worse than some other non-pharmacologic treatment. So we'll take a look at that right now. In fact, I took a look at this recently in a book I published last year, where we basically did, I invited expert colleagues from around the world to review different areas of treatment in ADHD. These are different areas of non-pharmacologic treatments. And I summarized these results in the slide I'm showing you here. First, this slide here shows you what we call quality of the evidence, which is how good the evidence base for different types of ADHD treatments. So they're ordered from the top to the bottom, from the best to the worst. So 5 is the best and 0 is the worst possible evidence. As you can see, the FDA-approved medications have the highest level of evidence, meaning they're very good studies, very well-designed studies, large numbers of subjects. We also have good data on omega-3 fatty acids, good data for kids in school-based interventions, and summer treatment programs, parent training, and so forth. As we go down the ladder here, you find the quality of the evidence gets worse. So when you look at diet or neurofeedback, family therapy, exercise, use of other kinds of supplements, even cognitive behavior therapy, social skills training, you find less evidence is available in terms of, or lower quality of evidence is available to address these studies.
This is not stating the efficacy of these different treatments. It's just talking about how good the evidence is that we have on these different.
Exactly. So first is quality of the evidence. So people have to recognize that for the most part, medications have great evidence. There's a few other areas that have great evidence, but most other areas, the quality is not so good. Now, you asked a very good question, which is how strong is the treatment effect? We don't have that actually for many studies that even report that. So we don't actually have that. But here you see treatment effect sizes where larger is better, and it's very clear when you've got enough data to support that the medications are showing a larger treatment effect than the non-pharmacologic treatments. So I'll compare, for example, stimulant medication with omega-3 fatty acids. So omega-3 fatty acids has a good evidence base, meaning there's lots of studies, good studies, and we can believe them. The problem is that those fatty acid treatments don't work real well. Their effects is roughly less than 0.2 versus almost 1.0 for, say, stimulants. When doctors and patients think about these kinds of data, they have to remember that they could look at it two ways. They could say, well, we should take the best possible treatment and start there. And frankly, that's my advice. I think that makes a lot of sense. I recognize that other people think differently. They think, well, we should take a treatment that has low risk, like omega-3 fatty acids. There's not a lot of adverse events associated with that, and give that a shot first, because if it works, well, then I don't have to take a medication. Mm-hmm. My answer to that is, well, if you go that route, you ought to be sure that the trial time is limited, and you don't spend too much time trying lots of different things out, because you could waste a lot of time before you got an effective treatment. Mm-hmm. And that if some people might spend a year or more trying different non-pharmacologic treatments before they go to a medication, and that could be a year or two or more of their life that's wasted. Mm-hmm. When I say wasted, meaning they're functioning at a much lower level than necessary because of the resistance to being treated with medication. So it's very important to weigh these. So there's a risk. The risks, people think a lot about the risks of taking medication, but they frequently don't think about the risks of not taking the medication. Mm-hmm. And there are real risks there. We talked about them before, right? Risks of traffic accidents, risks of doing poorly in school, risks of doing poorly in your occupation, risks in relationships. Right. Those are real life risks that people face when they choose to try treatments that are not as effective. So let's make some conclusions of what we said today. There's no doubt that ADHD is a brain disorder. There's well-documented diagnostic and treatment guidelines for doctors to use and for patients to understand that they can be diagnosed appropriately and then treated appropriately. ADHD is a worldwide disorder. It's not just an American disorder. It affects children, adolescents, and adults. It's a lifetime disorder for many people, although it does sometimes remit in adulthood. The impairments that we've seen with ADHD can be very serious, and we just talked about the whole range of them, from traffic accidents to premature death. It's not a disorder to be taken lightly. It affects the whole family, which is another way the disorder disrupts people's lives who have ADHD and who are around people that have ADHD. There's no question right now that pharmacotherapy is the mainline treatment for ADHD. The advice that I would give people to think about would be pharmacotherapy is a good place to start. And then if pharmacotherapy is not solving other problems in the person's life, it's not pharmacotherapy is not magic. It's not going to solve every problem. And frequently people with ADHD need adjunctive therapies or educational interventions to kind of fix the problems that the medication is not fixing. Mm-hmm. For example, in the case of adult ADHD, adult with ADHD might still have considerable problems, particularly if they were never treated. They may have chronic problems from, many years of not being treated. They may have developed many bad habits, and the medications aren't going to fix bad habits. So that patient maybe, for example, could use cognitive behavior therapy, which has been shown to be useful for adult ADHD, but importantly, it's only been shown to be useful in conjunction with medication, meaning that the studies of CBT show that if you compare medication only with medication plus CBT, the people who get both treatments do better than the people who just get medication. So I like to advise people to think of non-pharmacologic treatments as something you give after you've optimized somebody on their medication, so that you can then determine where are the residual impairments, and then focus your non-pharmacologic treatment on those residual impairments.
Mm-hmm.
So I think we're at the end. Do you have any questions for me, Jonathan?
Great. No, this has been wonderful. The wrap up was great. I hope this is this has been a real eye opener. We often hear about, as if you go back to the beginning of the presentation, the number of myths that are out there that are promulgated by so many different sources about ADHD. And Steve has really spent a career of building a set of data that shows that ADHD is real, ADHD has serious effects, and the medications that are available have, important impacts that really do help ADHD patients and their families. So this is a very valuable session we've had here, Steve. I really appreciate your time and bringing all this together. It's just a wonderful body of work you've done. Want to thank you again, Steve Ferrone from SUNY Upstate Medical University. Steve is the principal of ADHD in adults. This is Jonathan Marks from Inkwell Medical Communications and ADHD in adults. We want to thank you again for being part of this Ask the ADHD Expert sessions, and we'll be back again to answer more of your questions. Thanks, Steve.
You're quite welcome. Bye-bye.
Take care, everybody. Bye.